All right. Well, welcome back, and we're moving right through the chapters. We're up to chapter 12 at this point, and chapter 12 deals with drug and chemical classes. Um, I think I'm going to break this up into a couple parts because it's about 160 slides, so um, maybe break this up into two parts. And what we hope to get accomplished in these two parts is to list described drugs paramedics may administer according to local protocols, and that's going to vary depending upon where you work and what your medical director believes you should be using and giving. We're also going to integrate pathophysiological principles of pharmacology into our patient assessment. We're going to take patient history information and assessment findings, and from that form a field impression. And that field impression certainly will guide us in the direction of what sort of medications could be administered to help treat that problem they're having. We're going to discuss analgesic medications, including prescription and non-prescription meds. We're going to discuss anesthetics. We're also going to discuss serums, vaccines, and antidotes. We'll look at anti-infective agents, including antibiotics, antivirals, antifungals, antiparasitics. We'll look at anti-neoplastic drugs. We'll discuss vitamins and minerals. We'll look at fluids and electrolytes. We'll discuss and give examples of anxiolytics, antidepressants, mood stabilizers, and antipsychotics. We'll discuss and give examples of anticonvulsant drugs used for seizures. We'll discuss and give examples of muscle relaxers. We'll look at central nervous stimulants. We'll discuss meds used to treat Parkinson's and Alzheimer's. We'll discuss drugs affecting the parasympathetic division of the autonomic nervous system, or the feed and breed, or the cholinergic nervous system. We'll discuss drugs that affect the sympathetic division of the autonomic nervous system, or the fight or flight nervous system, the adrenergic nervous system. We'll discuss drugs that affect the cardiovascular system, including antiarrhythmics, antihypertensives, and vasodilators. We'll discuss the role of anticoagulants, fibrinolytics, and blood components in the management of cardiac emergencies as well. We'll discuss anti-hyperlipidemic drugs. We'll discuss oxygen, mucokinetic bronchodilator drugs as well. We'll discuss drugs affecting the renal system, the GI system, the eyes, ears, nose, and throat, the endocrine system, including hormones. We'll look at uricosuric drugs and drugs that affect the reproductive system. We'll look at drugs that affect the immunologic system. We'll look at dermatologic preparations, as well as drugs of abuse, including alcohols and amphetamines. We'll look at environmental chemicals, including herbicides, rodenticides, and insecticides. We'll discuss substances including alcohols, heavy metals, household chemicals, and hazardous materials. Excuse me. I think some of the general information we have to have when we talk about medications is an understanding of the following terminology. An indication, that's typically why is the drug being given, for what conditions is this drug being given. A contraindication is for what situations would this drug not be given. And it's important that we know that on each of the drugs that we carry so that we don't give it for the wrong thing. The dosage should always be checked against protocols, and or the dosage should always be checked against what is ordered by medical direction. When medical direction orders a medication, it would be a verbal order over the radio, and it's important that we use closed-loop communication in that situation, where if the medical director orders 1 milligram of epinephrine, 1 to 10,000, to be given slowly IV, that you repeat back, I'm going to administer 1 milligram of epinephrine, 1 to 10,000, slow IV, so that there's no mistaking what was ordered and what needs to be given. An overdose depends on the type of drug, and certainly the amount of the drug that's given determines whether or not it's an overdose. And when we arrive on scene, a patient may have overdosed on their medications, and if that is the case, then we need to look for those bottles, pills, needles, things that would indicate that they've had access to drugs. And if they've got a prescription, and it says take 1 tablet a day for 30 days, and there were 30 pills in there, and they just filled it yesterday, there should be 29 pills in there. And if there's only 10, then doing the math, we know they took 19 pills. So look for that sort of stuff, and certainly, and most importantly, knowing the number for poison control. And the 1-800-222-1222 is a number that no matter where you are in the United States, should you dial that, you're going to get a poison control center. As far as treatment goes related to drug overdoses, some of these medications certainly are going to be respiratory depressants as well as CNS depressants, and so level of consciousness may be altered, respiratory rate may be slowed, and some of these drugs certainly on overdose increase the risk of vomiting, which in a person who's unresponsive always increases the risk of aspiration. So monitoring their airway, their breathing, their circulation, getting a good set of vitals, obtaining a good history, hooking up your IVO2 monitors, and I add an S on the end of monitor because we have so many different monitors that are available to us. Blood glucose monitor, pulse oximetry, end-tidal CO2, all those things would be important to take a look at in treating a patient of an overdose. Attaching a 12-lead ECG, pulse oximetry, end-tidal CO2 would get you important information on the condition of your patient. As far as Epicac goes, or activated charcoal, on average, when people intentionally overdose on a particular medication, they'll wait 2 or 3 hours before they even seek help, and oftentimes later than that by the time they're found by somebody. And in those situations, the risk of giving these medications, Epicac or activated charcoal, far outweigh the benefit. The medication that was ingested is out of the GI, out of the stomach at least, within 3 hours, and so giving them Epicac to bring up something that's already absorbed and passed out of the stomach just really increases their risk of aspiration, and doesn't really isn't really beneficial. An activated charcoal designed to certainly coat the lining of the intestine and bind with what medication might be in the GI tract to prevent further absorption. Again, most of the medication, if patients are waiting that length of time, is already absorbed. And if you've ever administered activated charcoal, you certainly know that in itself increases the risk of a patient vomiting. So most protocols don't even have those in there. If they do, that's certainly a medical director preference, and I would gauge or determine whether or not to give that based off what poison control told me. Gastric lavage is something you might participate in if you work in a hospital setting, where they put in a tube, either a nasal pharyngeal tube into the nasal gastric tube into the belly, or an oral gastric tube through the mouth into the belly, and then pump the stomach. Medications for multi-system applications include analgesics and antipyretics. Essentially, analgesia, the thing to be concerned about analgesia, and we don't, we have very few analgesics that we can give to help relieve pain, but understand that the medications that we give are not without some serious side effects and may react with other medications that the patient takes. So it's important to know the current physiologic status when administering analgesics. Follow your local protocol on doses and the specific type of analgesia depending upon the patient's type of pain. As an example, there are people out there that are using nitrous oxide as an analgesic, and they use it quite successfully for isolated fractures, where some are using morphine for STEMI, heart attack pain. Others are using fentanyl for severe breakthrough pain. So there's a variety of different analgesics out there, and just follow your local protocols when administering them. If a person has pain, certainly to assess the pain, to identify what type it is it somatic or visceral, where's it coming from, and how severe is it, we can use the NOPQRST mnemonic, and you're familiar with that, where N is normal. You want to ask the patient, is this normal pain for you? Do you normally have this type of pain? And if so, what was the diagnosis and what do they do for it? O is onset. You want to know what they were doing to bring it on. P is provocation, what makes it better or worse. Q is quality. And here you want them to describe the pain. You don't want to ask them, is it sharp or dull? Because if you do, then you've just given them two choices, and if their pain doesn't fit into one of those two choices, they may not even describe what they're feeling. So just have them in their own words tell you what it feels like. R is radiation, does it go anywhere? S is severity on a 0 to 10 scale, with 0 being no pain, 10 the worst. Rate that pain, and then T is time, how long have you had it? Now, as far as non-prescription analgesics, and we certainly can give these over-the-counter medications in the ambulance, acetaminophen, which is abbreviated as APAP, trade name Tylenol. Acetaminophen becomes toxic if more than 4 grams or more than 4,000 milligrams are taken in a 24-hour period. And what's at issue here is that there are many products out there that relieve this symptom, that symptom, this symptom. As an example, many allergy medicines, cold medicines, those sort of things also contain acetaminophen. And if a person isn't reading the label, they certainly can double, triple, and quadruple their dose of acetaminophen every time they take it, because they're taking it based on the name of the product and not what's in it. So acetaminophen toxicity can be a real issue, and that's how much they would have to take to reach a toxic dose. Acetaminophen overdose, you'll have nausea, vomiting, stomach pain, loss of appetite, pain in your upper right side. And that's mainly because acetaminophen trashes the liver. And of course the liver sits in that upper right quadrant. You'll have dark colored urine. It can lead to confusion, seizures, coma, and death. Acetylsalicylic acid, say that 3 times fast, is aspirin. And the abbreviation for that is actually ASA, all capital. And aspirin toxicity occurs when you've taken more than 200 to 500 milligrams per kilogram of body weight. What you'll see with aspirin toxicity is CNS stimulation, so your central nervous system is overstimulated, vomiting, hyperactivity, fast breathing, deep breathing, possible seizures. Later it develops into respiratory depression, coma, respiratory failure, and systemic vascular collapse. Also, what's interesting to note, and it's not included here, one of the early signs of an aspirin overdose is fever, and you would think that that would be just the opposite. You've also got NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen, naproxen sodium. Those drugs reduce prostaglandin production, and prostaglandin production causes pain. So by reducing it, it alleviates pain, and it helps reduce fever as well. The toxic dose of NSAIDs is right up there with Tylenol, and that includes the symptoms include abdominal pain, nausea, vomiting, diarrhea, GI hemorrhage, pancreatitis. NSAIDs also affect the liver, so you could have pain in the upper right quadrant as well. Dizziness, confusion, depression, nystagmus, psychosis. The kidneys are affected here as well, so dark colored urine. And long-term non-steroidal anti-inflammatory use can cause certainly GI bleeding as well as kidney and liver failure. Opioid agonists include the phenethrines or phenethrines. I guess sometimes I put the wrong emphasis on the wrong syllable, and these come out a little strange, but I'm thinking phenethrines. We'll go with that. Phenethrines include your morphine sulfate, which can be abbreviated MSO4. That's the chemical abbreviation for morphine. Morphine sulfate includes hydromorphone, oxymorphone, codeines. They're all listed in the opioid agonist as an analgesic. The phenylheptylamine is methadone. That's an opioid agonist as well. And then phenylpiperidines is your fentanyl. Fentanyl is 10 times more powerful than morphine, and has fast become a standard analgesic in the paramedic drug box to help alleviate severe pain. It's not uncommon for opioid analgesics to be combined with other products. It lowers the potency of the narcotic and still helps alleviate pain. As an example, propoxyphene plus acetaminophen, that's Darvocet. Hydrocodone plus acetaminophen is Vicodin. Oxycodone plus acetaminophen is Percocet and Tylox. And codeine plus acetaminophen is Tylenol number 3. And these drugs, of course, because of their opioid content, do have a tendency to be drugs of abuse. They're used for acute pain, and right now their street value, because they're very difficult to obtain, physicians aren't readily writing scripts for these anymore. Their street value has exceeded the cost of heroin, and that's why we're seeing an increase in heroin use, because heroin is less costly than the street value of the hydrocodone or the oxycodone. Some partial opioid agonists include Stadol, Nubain, and Talwin. Some opioid antagonists, they reverse the effects. Agonists stimulate the effects of the opioid, and antagonists reverse the effects of the opioid. And the opioid antagonist that we have, of course, is Narcan. So in the event that we were dealing with a heroin overdose, or a morphine overdose, or a codeine overdose, or a fentanyl overdose, we could consider the use of Narcan. And an opioid toxidrome, or an overdose on an opioid, has a textbook presentation. You'll see these three things with an opioid toxidrome. A person will have an altered mental status, respiratory depression, and pinpoint pupils. Meiosis is the word for pinpoint pupils. Mydriasis is the word for dilated pupils. So meiosis is pinpoint pupils, and you'll see this just classic presentation. If you've got a patient who's not alert, awake, and oriented, respiratory rate's really slow, and their pupils are pinpoint, that's a classic opioid toxidrome, and the patient would benefit from the administration of Narcan. Anesthetics. We don't give anesthetics in the pre-hospital environment, but certainly if you work in a hospital, you may be around patients that have received some, particularly in recovery room, that sort of stuff. And anesthetics are CNS depressants. And certainly they'll use anesthetics for general surgery, but they'll also can use anesthetics to do what's called a digital block. In a digital block, lidocaine or some other anesthetic is injected into a nerve branch, and then that numbs a whole portion of a digit. So if they're going to do some work, orthopedic work on a finger, rather than put you to sleep, they may just numb that finger. And then we also see local anesthetics being injected directly into wounds, and or directly at a site to numb that area. And this is most common, of course, in dental work. It's also common for when you're suturing. There are levels of sedation that can occur as the result of administering a sedative or an anesthetic. There's minimal sedation, moderate, deep, and then general anesthesia. Certainly the most deep sedation, or the most where the patient is totally unresponsive to the point where you can do surgery on him, is the point of general anesthesia. We do minimal and moderate sedation for patients that are in severe pain. We don't depress their ability to breathe and have to breathe for them. We don't put them asleep. They can still be aroused with stimulus, sometimes to voice, sometimes to pain, but we never make them deep or provide general anesthesia. The stages of general anesthesia include analgesia, which is from consciousness till loss of consciousness. The excitement stage is what's also called surgical anesthesia, and then surgical anesthesia is when the breathing actually stops and the ventilator has to take over for them. Should the ventilator, of course, not take over for them, or should they continue to receive anesthetics, it can cause depression of the medullary center, the respiratory center in the brain, and paralysis, which could lead to shock. There are different types of anesthetics. There's certainly gas, and gas, of course, would be nitrous oxide would be an example of that that can be inhaled. Intravenous include barbiturates like phenobarbital, and then there are dissociative anesthetics. It's a class of hallucinogens which include ketamine, PCP, dextromethorphan, and nitrous oxide. Although nitrous oxide is a dissociative anesthetic, it isn't something we give IV. It's something that they inhale. Of those list of medications, we don't deal with PCP, angel dust. We might, depending on protocol, administer ketamine in place of etomidate for rapid sequence induction. Neuroleptic anesthetics are tranquilizers used to treat psychotic events, and they include Thorazine and Haldol. And then local anesthetics would be those that are injected directly into a wound, which is something we don't do. But if you work in a hospital emergency department and you're doing suturing, they'll inject 1 and 2% lidocaine or xylocaine into a wound prior to suture. The things that we would use anesthetics for include rapid sequence induction, and again, we're typically going to use things like etomidate, ketamine, to induce the sedation, and then some sort of paralytic, whether it be depolarizing or non-depolarizing, to paralyze them. We can use anesthetics for conscious sedation. If we've got a patient that we're going to synchronize cardiovert, we would want to sedate them, and those typically we're using things like Versed, Valium, as a sedative, and then some sort of analgesia like morphine or fentanyl. Anxiolysis is relieving somebody's anxiety, and we typically are going to use our benzodiazepines for that. So medications used as anesthetics include etomidate, It has anesthetic and amnesic properties, but it has no analgesic properties. So it doesn't do anything for pain, but it does sedate them. And they don't remember what happened. It works much better than the benzodiazepines. It's short acting, and we use it for rapid sequence induction. Fentanyl is a potent synthetic opioid analgesic, and here they say it's 100 times more powerful than morphine. It's often used in trauma. When compared to morphine, it's less likely to cause hypotension, and it has a short half-life, so that works well in the pre-hospital environment. Some medications used for immunizations, vaccines, and immunoglobulins include tetanus. Tetanus is a bacterial disease that's transmitted through cuts, puncture wounds, stepping on a rusty nail, and typically we get a booster every 7 to 10 years because you would not want to get tetanus. Kind of like rabies, once you get tetanus, there's no cure, and the mortality rates are high. Bacterial immunizations are administered to people who certainly are in close quarters, like in prisons, work camp, the military, college. They're also given to protect children and the elderly and those who are immunocompromised, and they include your flu shots and your pneumonia shots. Certainly those are bacterial immunizations that would prevent you from getting these sicknesses. They also, the streptococcal pneumonia and the flu shots reduce the incidence of bacterial meningitis, particularly in the military and college. Viral immunizations, immunizing yourself against viruses, because you know that once you're infected with a virus, there are no cures for viruses. We just have to treat the symptoms. So some viral immunizations include hepatitis A shots, hepatitis B shots, influenza shots, rabies, varicella, which is chickenpox, measles, mumps, and rubella, MMRs, which are immunizations that children get. And then immunoglobulins, they act as antibodies to specific viruses and bacteria. And we had discussed immunoglobulins in an earlier chapter. Antidotes are administered to counteract whatever the overdose was or whatever the poison was. And as an example, for organophosphate poisoning, the antidote is atropine. Anti-infective drugs include antibiotics, and penicillins were, your first generation antibiotics, and they were good at killing gram-positive or negative organisms. And then came the cephalosporins, which include things like Rocephin. And when patients were resistant to penicillin, allergic to penicillin, they would give them the cephalosporins. The macrolides include erythromycin, and erythromycin is an important antibiotic for respiratory infections, infections of the throat, skin infections, pneumonia, infections of the ear. Erythromycin works well for those. And then the tetracyclines include doxycycline, and those are used to treat respiratory infections, skin and acne infections. And then there's just a miscellaneous list of third and fourth generation, at least third generation antibiotics that include clindamycin, vancomycin, Flagyl, and these certainly are super antibiotics when nothing else is working. Flagyl works particularly well for infections in the gut. Antifungal agents. Antifungal agents are used to treat funguses, and the two most common that we see would be certainly yeast infections in women and thrush in babies. Antiviral agents, we know that again that viruses, there's no cure. Viruses cannot replicate or reproduce on their own. They have to have a human host, or the cell of a human, to act as a host in order for them to to replicate. And some of the more common viruses that we deal with in our society include influenza, which is the flu, and there is amantadine for that. Herpes, and here we're talking about herpes zoster, or we're talking about the shingles. And acyclovir is a antiviral agent for that. And then with human immunodeficiency virus, or HIV, those are the protease inhibitors, lamivudine and zidovudine. Zidovudine and lamivudine are medications used to treat HIV. Anti-malarial agents are agents used to combat malaria. Malaria is a single-celled parasite that's transmitted by mosquitoes. And some of the medications used to treat malaria include chloroquine, quinine sulfate, hydroxychloroquine, mefloquine, and doxycycline. Anti-tuberculotic agents are drugs used to treat tuberculosis. Tuberculosis is a microbacterium that affects the lungs and spreads systemically throughout the body. It's caused by inhaling infected droplets of somebody with tuberculosis. And the drugs used to treat tuberculosis is the rifampin, isoniazid, ethambutol, pyrazinamide. And of course, at least every other year, depending on the situation, people are required to get a tuberculosis test, a TB skin test, and if it's positive, that would indicate the presence of tuberculosis. Now, with the presence of tuberculosis, you then don't get a TB test. You get a chest X-ray every year to see if you in fact have tuberculosis. Amoebiasis, of course, they affect amoebas, and amoebas can get into your intestine and cause an intestinal infection from drinking contaminated water. And Flagyl is a common one given for that. Giardia is a intestinal infection that you can get from drinking mountain stream water, where animals upstream have defecated in the water. Anti-helminths. Helminths are parasites. They're found in pets, livestock, water, and they get into your intestines when you handle these things and then not wash your hands. And the symptoms include fatigue, weight loss, abdominal cramps, nausea, vomiting, diarrhea, and treatment is with these list of medications there: the albendazole, ivermectin. You can read them. I'm not going to stumble through, the pronunciation of those. Toxicity from these medications certainly include tachycardia all the way up to hypotension. Dehydration is common with the abdominal cramping, nausea, vomiting, and diarrhea. Leprostatic agents are used to treat leprosy, or what's also known as Hansen's disease. It causes skin lesions, peripheral nerve damage, and progressive debilitation, sloughing off of tissue, that sort of stuff. And Dapsone is the medication for that. Anti-neoplastic agents. There are 6 different types or groups of anti-neoplastics, and there's quite a few in each group. So the list of these cancer medications are extremely long. They interrupt the development and growth and spread of abnormal cancer cells, and we'll use an oncologist to prescribe those particular medications. Of concern to us is, if an anti-neoplastic is a if an anti-neoplastic is has radioactive stuff or chemotherapy drugs, some of the chemotherapy drugs, we have to be very careful in patients on chemo when handling their blood and body fluids, particularly body fluids and particularly urine. Side effects of anti-neoplastic agents include nausea, vomiting, diarrhea, loss of appetite, mouth sores, easy bruising, headache, hair loss, hearing loss, cough and shortness of breath, jaundiced skin, dark urine, those sort of things. Vitamins and minerals include fat-soluble vitamins stored in body fat, and they can cause toxicity in excess. You can have too much vitamin A, D, E, or K, and certainly the in toxic cases, there's a wide variety of treatment that has to occur, and I would contact the Poison Control Center if I suspected my patient had overdosed on their multivitamin. There are some water-soluble vitamins like vitamin C and vitamin B, and when you get your sample history and you're asking about, do you take any medications, it's important to include, over-the-counter medications and herbal remedies. As far as fluids and electrolytes go, we certainly administer fluids to patients. It's under great debate as how much and which one and those sort of things, and we'll talk more about that in other chapters. But currently, the crystalloid solutions we have available to us include normal saline, lactated Ringers or Ringers lactate, D5W. They've got D2W in the slide, but it's D5W, and half normal saline would be half the salt concentration of what you'd find in normal saline. Normal saline is a 0.9%, so a less than 1% salt solution. And Ringer's lactate, it has some salt, but it also has some potassium, it has some lactate, it has some other things in them that make it more desirable in burn patients who are receiving large amounts of fluid over time. D5W is a 5% sugar water solution, and again, the half normal would be a 0.45% salt solution. And you can have a combination of these. You can have D5LR, you can have D5NS, you can have D5 half normal, you can have D5 quarter normal, and so there's a variety of combinations. In most trucks or buses, we're seeing just the normal saline being carried. So drugs that affect the nervous system include anxiolytics, and the most common anxiolytic or drug that we give to relieve anxiety are going to be your benzodiazepines. We give those for anxiety, we give them for muscle spasms, to terminate seizures, and also as part of conscious sedation. They include diazepam, lorazepam, and midazolam. Diazepam is Valium, lorazepam is Ativan, and midazolam is Versed. The antidote, of course, for an overdose of a benzodiazepine is going to be flumazenil. That's the antidote. That reverses, that's a benzodiazepine antagonist. Barbiturates. Barbiturates are anxiolytics as well. It's not something that we would administer in the field, but perhaps a patient who suffers from an anxiety disorder may take some. Some of the barbiturates out there, the ultra short-acting pentothal, short-acting seconal, and then intermediate-acting amytal, and then the long-acting would be phenobarbital and luminol. Phenobarbital was certainly a very common anti-convulsive medication given to patients who have seizure disorders, and it's one of the first-generation anticonvulsants. Antidepressants are used to treat depression. They're also used to treat bipolar disorder, other mood disorders as well, and smoking cessation. Years and years ago, Wellbutrin, which is an antidepressant, but it's not a very good antidepressant. Patients who took Wellbutrin lost their desire to smoke. So the company remanufactured the product. Wellbutrin actually didn't remanufacture anything. They just renamed it, and they called it Zyban. And in the 90s, Zyban was a first-generation smoking cessation drug that you would take. You also had your mood enhanced, and you had no desire to smoke. Also in the class of anxiolytics include selective serotonin reuptake inhibitors, or SSRIs, and they're used to treat depression, anxiety, OCD, disorder, obsessive compulsive disorder, bulimia, and they block the uptake of serotonin at the nerve synapse, and it's believed that by blocking the serotonin that enhances the mood. You can overdose on these. It's really hard to do that, but when you do, you would see agitation, restlessness, nausea, and vomiting. And the most common SSRIs out there would be Celexa, Lexapro, Prozac, Paxil, Zoloft, and they're widely prescribed. They're the feel-good pill. So if you're not feeling good about anything, they're administered, or scripts are written for patients all the time. So it's a very common med that you're going to come across. One of the newer ones out there, actually newer than the SSRIs, are the SSNRIs, selective serotonin norepinephrine reuptake inhibitors. And they not only block or delay the reuptake of serotonin, but they also block and inhibit the uptake of norepinephrine. And by doing that, the reuptake. They block or delay the reuptake. Yeah, so they block the absorption of those chemicals. Taking this, and by blocking serotonin and norepinephrine, it's believed that also enhances mood. The SSNRIs include Cymbalta, Effexor, Pristic, and Fetsima, and the overdose symptoms are the same for your SSRIs. The other issue, backing this up, the other issues about SSRIs and SSNRIs is these aren't medications that you can take and then just go cold turkey. You have to wean yourself off them, and if you don't, you go through many of the same withdrawal symptoms that a crack addict or an alcoholic would go through as well. Tricyclic antidepressants, they were around long before we had SSRIs and SSNRIs. So they're like first generation anti-anxiolytics, and they block the reuptake of norepinephrine. And it helps relieve depression. But tricyclic antidepressants, you can overdose on these, and the overdose can be life-threatening. Whereas the overdose on an SSRI, you probably wouldn't have enough in possession to overdose on an SSRI. They're just not likely to happen. It's known that certainly if you're depressed that thoughts of suicide do occur, and when they occur, the potential for overdose is there as well. So tricyclic antidepressants, people would take them, they would overdose on them, mortality rates were high, those sort of things. And then out come the SSRIs, which do a better job, and if they are taken as a form of an overdose, it's not likely they're going to do anything. But back to the tricyclics, they include imipramine, clomipramine, nortriptyline, and doxepin. And these tricyclic antidepressants, when you overdose on them, one of the things that you'll also see is a significant increase in premature ventricular contractions, or PVCs, and they may be significant enough to cause cardiovascular compromise, And the treatment is to slightly alkalinize the blood and the PVCs go away. So, an antidote might be for tricyclic antidepressants giving some sodium bicarbonate. But I would want to call poison control for that. Monoamine oxidase inhibitors, or MAOIs, they're organic compounds that include neurotransmitters in the human brain. So dopamine, epinephrine, norepinephrine, serotonin, and what these do, these MAOIs, is they prevent the breakdown of the monoamine neurotransmitter. And by doing so, they boost mood. This was definitely a very early first-generation anxiolytic, and most have been replaced. I mean, I'm sure there may be people on them, but I'm just not aware of anybody that takes an MAOI. They include things like Marplan, Nardil, MSAM, and Parnate. So if you come across them, you know that they're really early generation anxiolytics. There are drugs out there that help stabilize mood, drugs that help improve mood, get you up, get you feel good, but in those situations where you feel, manic, you need something to stabilize that mania. And mania is the second component of the bipolar disorder. A person who suffers from bipolar disease vacillates between depression and mania. When they're in their depression stage, they can't get out of bed. They're severely depressed. Heavy thoughts of suicide, that sort of stuff. When they're manic or they're in their mania stage, they can be awake for days. They don't require any sleep. They get a lot of stuff done. Their ability to problem solve and think is just really out there because of all the dopamine that's being circulated. When they're in their manic stage, they also participate in activities that are dangerous. Certainly the use of other chemicals to keep that mania up there. They like being manic. They don't like the depression part of the disease, but they like their mania. So drugs like lithium have been around for a long time, and lithium helps stabilize a mood during their manic stage, and prevents them also from going into the depression stage. Valproic is another mood stabilizer, as well as Tegretol. Tegretol is also used for, as well as valproic acid and Tegretol are also used for seizure disorders. Antipsychotics, they're used to treat psychosis and schizophrenia, and they primarily work at the dopamine receptors and block the reuptake. But antipsychotics have some side effects, particularly QT prolongation, that can be life-threatening. Anytime you increase the length of the QT interval, as we'll learn in the cardiology section, you increase your risk of sudden death. They also cause headaches, sleep inability, dizziness, nausea. Tardive dyskinesia is twitching. Some types of antipsychotics include your Haldol, Navane, Thorazine. Geodon is popular in our mental health unit. Radepton is one. Olanzapine. Zyprexa is another. An atypical antipsychotic that patients may take. They don't work like the drugs we've listed above, but they do help treat psychosis and schizophrenia. And they include Zyprexa, Abilify, and Risperdal. Anticonvulsants are used to treat seizure disorders and to treat epilepsies. While there are many people that have seizures, only about 25% of them are actually epileptic, and there's about 25 different epileptic categories, different types of epilepsy. Another 25% of people who have seizures, they can attribute it to something like lack of sleep or hypoxia or a brain injury or those sort of things. 50% of all seizures, however, are idiopathic. They have no idea why they're caused. And anticonvulsants in those people who have convulsions these drugs depress the neuron excitability, and they terminate these massive uncontrolled discharge of the brain neurons, which is what causes a seizure. They include the hydantoins, and they're effective for most seizures. And they include phenytoin, dilantin, and they take effect by changing how the sodium ion is transported across the neural cell. Barbiturates, we've all talked about barbiturates already, but barbiturates can also be used to treat seizures, and I had mentioned phenobarbital as being a central acting CNS depressant. Of course, barbiturates are also sedative hypnotics, but in excess, barbiturates can cause agitation, confusion, slow respiratory rates, low blood pressures, nausea, vomiting, that sort of stuff. The succinimides, they're used to treat seizures as well. They alter the wave spikes of the activity in the brain, and they include ethosuximide, phenosuximide, and methosuximide. Benzodiazepines, we use those as anti-anxiolytics, but they are the primary medication that we're going to give to stop a seizure. So if we arrive on scene and a person's actively has a active tonic-clonic seizure or grand mal seizure occurring, we're going to look at either establishing an IV or an IO, or these meds can be given a variety of ways, intranasally, rectally in children, those sort of things, to terminate the seizure activity. And they, of course, are benzodiazepines include diazepam, lorazepam, and midazolam. And again, diazepam is Valium, lorazepam is Ativan, and midazolam is Versed. Some others that are given not to break the seizure but to prevent the seizure from occurring, they're given as a preventative medication, include valproic acid, which is Depakote, the carbamazepine, which is Tegretol, gabapentin, which is Neurontin, and topiramate, which is Topamax. If a person would overdose on the preventative medications, I would be contacting Poison Control to figure out if there is an antidote or what I should be doing in that particular situation. Now, muscle relaxants do just that. They relax muscles, and muscles can be tense, muscles can be tight as a result of injury, overexertion, herniated disc of the spine. Tetanus is a disease that causes muscle contraction, and then illness. And so giving medications to relax those muscles can be very helpful. There are some central acting skeletal muscle relaxants. They do not help with healing, but they do ease the symptoms. So if somebody has muscle pain as a result of a twisted ankle, it's not going to help with the healing of the ankle, but certainly would help ease the pain that's associated with it. Side effects of these central acting skeletal muscle relaxants include dry mouth, dizziness, drowsiness, lightheadedness, restlessness. And some of the relaxants, of course the one I'm most familiar with is Flexeril. But back in the day, we saw a lot of people taking Paraffin Forte, Soma, Robaxin is another one as well. So when you see these drugs, you know that they are muscle relaxers. Direct-acting skeletal muscle relaxants that work directly on the muscle rather than alleviating the pain are your hydantoin derivatives like phenytoin, which inhibits the release of calcium. When calcium moves into the muscle cell, it causes a contraction of that muscle cell, a prolonged contraction of that muscle cell. So these direct-acting skeletal muscle relaxants like phenytoin inhibit the release of calcium into the cell. CNS stimulants block neurotransmitters in the brain, and they include things like anorexiants, which suppress appetite for weight reduction, One of the medications that's used for anorexia is sibutramine, but the side effects include headache, back pain, palpitations, chest pain, and of course an allergic reaction. Amphetamines are CNS stimulants as well. Amphetamines, methamphetamines, they stimulate the brain portion responsible for alertness. So amphetamines may be given to treat narcolepsy, given to treat attention deficit disorder. They are controlled substances because of their addictive properties. And amphetamines can be made into methamphetamine, which certainly has a street value and is very prevalent in our society today, and methylphenidate is another derivative of amphetamines. Drugs for specific CNS peripheral dysfunction include drugs for Parkinson's disease. Levodopa is the medication used to help treat Parkinson's disease. And Parkinson's disease is a brain disorder where the nerve cells that control movement are damaged, and so a person with Parkinson's disease, shakes quite a bit. Alzheimer's disease, Aricept is the main drug that's out there now to help with retention of memory. Alzheimer's disease is caused by amyloid plaques that develop in the brain, and by replacing acetylcholine lost from the parasympathetic nervous system, there is an improvement in memory. Huntington chorea, the drug for that is Klonopin, and that's when you have an imbalance between dopamine and acetylcholine in the brain. It presents with a progressive dementia, but then also involuntary muscle movement along with the dementia. Drugs that affect dopamine, and dopamine's it's a neurotransmitter. It's released by your kidneys. It's very important in your bloodstream for mood. It's very important in your bloodstream to problem solve, make new memories. It's a really important neurotransmitter. And drugs that affect dopamine include your anticholinergics like atropine, your monoamine oxidase inhibitors, your MAOIs, dopamine agonists, and dopamine substitutes. Other drugs that affect the autonomic nervous system or the cholinergic nervous system, so drugs that are going to reverse the effects of cholinergic function, include anticholinergics like atropine. Atropine is an anticholinergic. It occupies the receptor sites on the organs where acetylcholine would slip into. And acetylcholine, particularly when we're talking about the heart, acetylcholine causes the heart to slow way down. So if we have an excessive amount of cholinergic function in our system, if we're stimulating our vagus nerve and releasing lots of acetylcholine into our bloodstream, then our heart rate's going to slow way down. And atropine is an anticholinergic. It binds in those sites, and the acetylcholine can't slow the heart rate down. Ganglionic stimulants include nicotine, and in your autonomic nervous system, in addition to your acetylcholine receptor sites, you also have muscarinic and nicotinic receptors. Acetylcholine fits into those muscarinic and nicotinic receptors. The muscarinic receptors cause you to sludge, and the nicotinic receptors cause you to twitch, fasciculate, and cause muscle paralysis. So nicotine is a ganglionic stimulant. Ganglionic blocking drugs include trimethoprim as well. Drugs that affect the adrenergic nervous system or the sympathetic nervous system, fight or flight. We have adrenergic drugs that we give. They include epinephrine, norepinephrine, and dopamine. We'll learn more about those drugs in our cardiac portion of the course. But certainly if somebody's heart rate needs to increase, we can give epinephrine. If somebody's blood pressure needs to increase, we could give norepinephrine. If somebody's heart rate and blood pressure need to increase, we could give dopamine. Dopamine is a synthetic drug that we give that does different things at different dosages. And we'll talk again more about that in our cardiac section of the program. Adrenergic blocking drugs include your beta blockers. These adrenergic drugs work because they go in and occupy beta-1 receptors on your organs and alpha receptors on your organs. So to not have the heart rate increase, we can give beta blockers, or if a patient has a history of tachycardia and they can't slow their heart rate down themselves and keep it at a good level, if they're constantly running in the hundreds, well, then they'll take beta blockers. And beta blockers are drugs that end in LOL. So metoprolol, propranolol. So your LOL drugs are beta blockers, and they're used to slow the heart rate down. All right, we're at just a little over an hour on our presentation, so I think I'm going to end it here at drugs that affect the cardiovascular system. And when we come back, we'll pick up on this particular section. So go ahead and take a break, and I'll talk to you soon.